Good evening. I'm Tony Segreto, the moderator for tonight's In the Know Town Hall. We welcome you to this informative series of UHealth and Miller School of Medicine leaders, experts on a range of health topics. Tonight, we will discuss a perfect topic for February when we celebrate American Heart Month. Heart disease is the leading cause of death in the United States. It affects people from all walks of life. It's not discriminate. Thankfully, we have an incredible team of physicians and researchers at UHealth and Miller School of Medicine who are continually finding new ways to eradicate heart disease and stroke. Our panelists tonight include experts in cardiology, interventional cardiology, preventive cardiology, and cardiothoracic vascular surgery. Let me first welcome Dr. Joseph Lamelas, Chief of Division of Cardiothoracic Surgery and Professor of Surgery at the Miller School of Medicine's DeWitt Family Department of Surgery. Dr. Lamelas is world-renowned for developing minimally invasive valve replacement techniques in surgical interventions. Welcome, Dr. Lamelas. Indeed, this is a real honor to share the panel with you.
Thank you, Tony. Much appreciated. And I'm very delighted to be here tonight and joining all the viewers. And as Tony mentioned, I'm the Chief of Cardiac Surgery at the University of Miami and also Professor of Surgery at the Miller School of Medicine. And, you know, as Tony mentioned, heart disease is definitely the #1 killer in the United States. And unfortunately, the world only looks at February as Heart Month, but we as professionals and physicians in University of Miami, we dedicate every waking moment of our lives to not only the care of the patient, but cardiovascular research. And at UHealth, what we have done is we've brought together a multidisciplinary team in order to care for the heart in whole, not only with cardiologists, but with surgeons and researchers as well. And we offer the entire gamut of cardiac procedures, from medical therapy to cardiology interventional procedures, as well as surgical procedures that are even minimally invasive. And having said that, I heard many techniques to approach different valves in the heart, the aorta, congenital defects, arrhythmia surgery. That's all done through a 4 or 5 centimeter incision between the chest, which is the least traumatic way to approach the heart. And having said that, I am joined with one of my esteemed colleagues, Dr. Ghahramani, who's the director of echocardiography. And between he and I today, we're going to take the questions from the audience and hopefully enlighten you a little more on what we do on a daily basis, and also to clarify some of the questions you have to help your health long term, especially cardiac health. So, Tony, I'll turn it back to you. So maybe you could take some of the questions, and Dr. Ghahramani and I would be happy to answer them.
Okay, thank you, Doctor. Now let's go over how you can participate in tonight's conversation. In just a minute, our panelists will answer the questions that you submitted over the last few days. You can also submit questions during this program. Please use the Q&A feature right here at the bottom of your screen. And remember that questions are submitted anonymously. We will get to them as many of them as we possibly can. Our first question is for both of you. Do men and women experience the same symptoms associated with heart disease? And is it true that women get diagnosed with heart disease much later than men?
Yeah, thank you so much. It's an honor to be here. Thank you, Dr. Lamelas, for your introduction. That's a very good question. Although symptoms tend to be, some symptoms are shared between men and women. Women tend to have more atypical symptoms, especially when it comes to coronary artery disease and heart attacks. And they tend to be diagnosed, and they tend to have coronary artery disease specifically later in life than men do. So to answer the question, yes, the symptoms that women have when it comes to heart attacks and coronary artery disease are different, and women could have more atypical symptoms, including shoulder pain and jaw pain, as opposed to the typical chest pain that is the most common side effect of a heart attack or coronary artery disease.
Dr. Lamelas?
Yeah, I mean, what's interesting, as I've been in practice 33 years now, and what's interesting is more and more, I mean, there's more of an awareness of coronary disease. And in the past, we used to think it was only the men that would be affected by coronary and valve disease. And now I see probably an equal number of men and women that require surgery, both coronary disease as well as valve surgery. And women have a slightly higher predisposition to develop problems with their mitral valve. So you hear that a lot, that a female patient may have mitral valve prolapse. And that doesn't necessarily mean you need surgery, but it's something that you need to be aware of. So this is followed long-term by an echocardiogram, which is Dr. Ghahramani's specialty. And some of these valves do progress to the point that they will require surgery. So again, careful surveillance of the valve and long-term follow-up is extremely important.
We want to mention to all of you that Dr. Cox was supposed to join us tonight, but unfortunately he had an emergency and had to be pulled away. So we just get stuck with Dr. Ghahramani and Dr. Lamelas. That's not too bad. Dr. Ghahramani, what tests should your cardiologist prescribe annually that could avoid having heart-related episodes?
I think the most important thing when it comes to staying on top of your heart health is prevention. And one of the most common causes of heart disease is having high cholesterol. So if there's one test that I want to make sure that everyone above 40 years of age is doing on an annual basis, is a lipid profile or checking your cholesterol on an annual basis. And then there are, based on your risk factors, there are other tests that we can do, including coronary calcium score and some other modalities that can help us risk stratify you more. But I think for the general population, at the very least, a lipid profile on an annual basis, what's recommended.
Dr. Lamelas, what is minimally invasive aortic valve replacement surgery, and what are the benefits? Is it better than open heart?
Right. Well, the minimally invasive approach is an operation that's done through a 4 or 5. For the aortic valve in the mitral, it's done through a small incision on the lateral aspect of the chest wall. For an aortic valve, it's usually in this area right here, which is in the upper part of the chest, and it's a 4 or 5 centimeter incision where the rib is not broken and the vascular supply to the chest wall is not interrupted. And then utilizing specialized instruments, I would go and take the valve out and replace it with a brand new valve. And this is probably the least traumatic approach to access the aortic valve and also the mitral valve. And what that translates into not only a shorter recovery in the intensive care unit, but in the hospital, but also back to a normal lifestyle. The risk of transfusions is a lot less, and the ability of the patient to ambulate and mobilize after the operation is significantly improved. And I've seen this translate in much better outcomes compared to the traditional sternotomy open heart procedure.
Dr. Ghahramani, my doctor ordered a coronary calcium score. Are there new uses of the results of this test to help personalize treatment for heart attack prevention?
There aren't really new uses, but as going back to the previous question that I answered, it's coronary calcium score is one of the best tests now we have, most sensitive and specific to risk stratify patients based on the amount of calcium buildup they have on their coronary arteries. So in patients that what we call intermediate risk, we get a calcium score and it makes us decide whether we want to be more aggressive with lowering their risk.
Both of you can weigh in on this next one. Can diet and exercise help aid in maintaining a normal heart rhythm?
Well, the rhythm, there's different components of the heart. One is the valves, which are the structures inside the heart. The other is the plumbing or the coronaries, and the third is the electrical component. Now, the rhythm part, obviously, exercise and diet are going to be essential in the overall health of the patient, but it doesn't necessarily translate into any changes in the rhythm. The rhythm has to do, the most common arrhythmia that I see, and I'm sure Dr. Ghahramani sees, is atrial fibrillation. And when you have atrial fibrillation, if it's new onset, the most important thing is to see an electrophysiologist. So that they could address this, because what you don't want is to live with atrial fibrillation long-term, because then you'll need to be on anticoagulation. But the biggest risk of having atrial fibrillation is that you could develop a stroke. And there are ways now that we could treat the atrial fibrillation either with cardioversion, medications, or an ablation. And those are very important to address with the electrophysiologist. So the key takeaway point here is really not to allow atrial fibrillation to progress long-term, because we have very effective ways of treating it now. But let me just add that if you let it go for many, many years, it becomes much more difficult to treat, and the risk of stroke will be incremental.
Yeah, thank you, doctor. Thank you, Dr. Ghahramani. Once you get a pacemaker, how likely is it that you will need it to be replaced?
The battery needs to be replaced, just like any other machinery. The pacemaker comes with a battery, and depending on the type of pacemaker, why you have the pacemaker, and how often you're actually being paced with the pacemaker, the battery needs to be changed either sooner or later. But the typical battery life for a pacemaker is about 6 to 10 years. And you don't have to replace the whole pacemaker, meaning the leads and other components, but the battery and the generator will need to be replaced every 6 to 10 years.
Thank you. Dr. Lamelas, is a stent delivered by a wire still the best way for aortic insufficiency?
Well, I think the question needs to be answered a little differently. Stents are usually implanted in the coronary. So if you have a blockage in one of the arteries in the heart, a stent is implanted into the coronaries. Now, the TAVR, which is a valve that's implanted through the groin that goes into the aortic valve, that's usually reserved now for patients that have aortic stenosis. There are new valves that are being developed for a leaking aortic valve, which is aortic insufficiency, but they're not approved for use on a daily basis. So they're still investigational. I mean, there's some that have been used for specific instances, but again, the most common indication would be for aortic stenosis, and that would be a TAVR. But not every patient should have a TAVR, and we could get into that later on if you like. But TAVR is one of the solutions to treat patients with aortic stenosis.
Thank you, doctor. Dr. Ghahramani, I've heard about artificial intelligence. Can this new technology be used to detect and prevent heart attacks?
Obviously, it's relatively new technology in medicine. We are utilizing artificial intelligence in various ways. I don't know of any data with regards to attacks, but we are using artificial intelligence for imaging, detecting coronary artery disease, detecting valvular heart disease with CT, MRI, echocardiograms. But as far as detecting and preventing heart attacks, no technology that I'm aware of that has been researched enough.
Dr. Lamelas, why do I still have on and off chest pains after I've had 2 cardiac caths?
Well, you could, if you have residual coronary disease, I mean, you could have the fact that one thing is having a catheterization only, but if you've had a catheterization with a stent and you still have blockages in some of the smaller arteries in the heart, you can have residual chest pain. But again, I think that's important to reach out to your cardiologist, because you may need either a repeat catheterization or a stress test, some other study to detect if you have ongoing ischemia or lack of blood flow to important portions of the heart.
And Dr. Lamelas, how is a leaking valve dealt with?
Right, well, the heart has 4 valves. I mean, the main is 3 valves that we deal with, mostly the aortic valve, the mitral, and the tricuspid. And each of those can develop a leak. And, the valves in the heart function like doors that open and close. And when those valves start leaking, the treatment, we have multiple treatments, but depending on the risk factors of the patient and the age of the patient, if the patient is an adequate candidate for surgery, then we do treat the valves with a replacement
Okay, thank you, doctor. Dr. Ghahramani, does a heart that is weak repair itself over time, or can a weak heart lead to a stroke?
With regards to the first question, it depends on what the cause of the weakness of the heart was to begin with. The most common cause is coronary artery disease or having a heart attack. If that's the case, you really want to address the underlying problem, treating the coronary artery disease by stenting or doing bypass grafting. And we have medications that are very effective in recovering the function of the heart. And there are various other reasons for the heart muscle to be weak. So that's, I think, the important point is to figure out why the heart is actually weak. The other question was, the second part of the question was, if you don't mind repeating that.
Do you think itself over time, can a weak heart lead to a stroke?
Yes. So when your heart is weak, blood becomes stagnant in the chamber of the heart, and stagnant blood may result in blood clot formation. And if there's a blood clot formation, then it could end up leading to a stroke. But if we find a blood clot in the heart early enough, we can treat it with blood thinners, so that way we can prevent a stroke.
Thank you. Dr. Lamelas, do you think people with mechanical heart valves will ever be able to take any of the newer anticoagulation drugs?
I think we lost Dr. Lamelas.
Well, can you answer that, doctor?
Yes. So there haven't been the traditional blood thinner for a mechanical heart valve is warfarin or Coumadin, which is the oldest blood thinner we have. And that's been the most effective to thin the blood in patients who have mechanical heart valves. Now we have newer generation anticoagulants or blood thinners that are very effective, but we have not had any large studies to show that they're safe and effective in the specific group of patients with mechanical heart valves. So that's still a dilemma. So still the recommended guidelines are to use warfarin or Coumadin for mechanical heart valves.
Interesting. What is a good level for bad cholesterol? Used to be below 100, then 70. Now I hear between 50 and 70. And how to get to that level, even if I eat healthy, eat right, do not drink, and exercise all the time. What do I have to do to get it right?
So we are not, we have kind of swayed away from having a cutoff value for what's normal, what's abnormal. It depends on your risk and your medical history. For example, if you have a history of stroke or a heart attack, then your bad cholesterol or LDL should be less than 70, and sometimes even less than 50. But if you haven't had a heart attack or coronary artery disease or diabetes, if your risk is low, or your risk of having a heart attack is low, then we are more lenient with that number. As far as lowering the number, the most effective way is diet and exercise. And if you're not successful with that, then we recommend cholesterol lowering medications. The most common ones and the oldest ones available being statins.
Thank you, doctor.
Yeah.
Dr. Lamelas, you back with us?
Yes, I'm here. Sorry.
Okay. I have heard of individuals who have had bovine animal valves that have failed. Is there any new research or innovation around artificial valves or regeneration of a new valve tissue?
Right. So we have tissue valves, meaning biologic valves either made of cow tissue or pig valves. And the latest generation valve that we have, the latest tissue technology is one from it's a cow valve, and we're hoping that valve would last 15 years or longer. But there's also new valves being made of polymers that are also in the developmental stage. But the quest is to have a valve that'll last the longest and only need to be on one aspirin a day, because patients do want to avoid taking any stronger anticoagulants because of the higher risk of bleeding.
Interesting. Dr. Ghahramani, does cancer pose a greater threat to women's health than cardiovascular disease?
Cardiovascular disease is still the #1 cause of mortality, both in men and women. So based on, if you go purely by data, then cardiovascular disease is a higher risk. Yeah.
Okay. Dr. Lamelas, can you repair an aorta minimally invasive similar to valve replacement? Can you replace it?
So the aortic valve can be repaired. I mean, and again, it's on an individualized basis. The mitral valve, for the most part, if the patient has mitral insufficiency, those valves could, I would say, have a 98, 99% chance of being repaired. And what a repair is to actually use your own native tissues to reconstruct the valve so it functions the same way as it did when it was normally functioning. And there's many different techniques in a repair of the valve, but no matter how we finish, no matter how we repair the valve always ends up with a ring around it to stabilize the repair long term.
First of all, we want to thank all you for sending the questions in. And then secondly, keep them coming. This is for both of you. What is female-specific disorders that increase women's risk for heart disease? Is the University of Miami doing anything unique to their approach for patient care for a woman presenting with symptoms of heart disease?
So to answer the second question, we are actually in Division of Cardiology. We are establishing and expanding a women's cardiology program, and we are in process of putting that program together. So stay tuned. As far as women specific goes, yes, postmenopausal women, hormonal issues as a result of that result in increased risk of cardiovascular disease. And then besides that, traditional risk factors such as high cholesterol, smoking, diabetes could also increase your risk of coronary artery disease or a heart attack specifically.
I have to ask both of you this question. Why do women not get treated the same way, or we don't hear about women as much as we do about men and heart attacks?
No, but I think that perception has changed because of awareness. So I think more women are getting attention because they're seeking the attention as well. Because in the past, one always thought that the men were the one that were more predisposed to heart disease and valvular disease. But again, I think it's equivalent in both male and females.
How just in Dr. Lamelas, how is aortic regurgitation diagnosed?
Right. The most common way is initially by auscultation, by a stethoscope on the chest, but sometimes that could be underdiagnosed. So an echocardiogram would be the next procedure, and that's done. It's a sonogram of the chest to look at the valves within the heart. And aortic insufficiency as well is a pathology that I think and many specialists think goes undertreated, because in the past the philosophy was thinking, let's wait till the patient becomes symptomatic or the heart muscle begins to dilate. But I think in this day and age, if we wait to that point, we've waited to a point where the disease is pretty advanced, and we could still benefit the patient, but the long-term benefit will not be the same if they've had their valve addressed earlier in the pathology or the course of the disease.
Interesting. Dr. Ghahramani, we've had this just sent into us. What can cause scarring in the ventricles and the heart? Can a gene mutation cause the scarring?
The most common cause of scarring in the ventricle is a heart attack, is because when lack of blood supply as a result of a heart attack results in necrotic issue. Basically, the tissue in that area dies, and over time it becomes scarred. Now, there are other causes of scarring, such as genetic cardiomyopathies that we call them, or familial cardiomyopathies, that could happen without a heart attack. And yes, there's a genetic etiology for that as well. And the biggest concern when you have scarring is your risk of having arrhythmias as a result of that.
In addition to that, if you do develop a scar in the heart, it decreases the contractility or the function of the heart muscle. And that, as Dr. Ghahramani mentioned, that if you have a heart attack and it's not addressed, that muscle will begin to die off, and that muscle that's dead becomes scarred down. And sometimes that scarring could cause an aneurysm of the ventricle. We don't see that often today. It was a pathology that occurred more often years ago because of the fact that patients that had heart disease would not go to the hospital. They'd have a heart attack at home, and those that did survive may develop aneurysms or significant dysfunction of the heart muscle.
Interesting. This just in. So this is for both of you. Why would I be experiencing heart palpitations still after having mitral and tricuspid valve repair done on December 2021?
Right. So there's two things. Somebody who's had undergone recent surgery, there's a difference between having palpitations versus having arrhythmias like atrial fibrillation. So some patients, they early on, because of a little bit of inflammation around the heart, they may feel that they're having palpitations, but in reality they're not. If they are feeling that, they need to be on a monitor to make sure that they're not having atrial fibrillation. And if that were the case, then that could be easily treated. And we do see 15-20% of patients after any type of cardiac surgery will develop atrial fibrillation, even if they've never had it before.
For Dr. Ghahramani, can you have high blood pressure and not have any additional heart issues along your life, and along with your life still be treated?
Sorry, if you don't mind repeating that.
Can you have high blood pressure and not have any additional heart issues along your life if it's treated?
Yes, absolutely. And that's why it's extremely important to treat blood pressure early on. They call blood pressure the silent killer. So if you get your blood pressure under control and you treat it early enough, you can prevent a lot of the long-term damages that high blood pressure could do, including hypertensive heart disease, which is effect of high blood pressure on your heart, stroke, and so on and so forth. So absolutely, yes. And it highlights the importance of treating blood pressure early on.
Dr. Lamelas, can you talk about defective HDL and what you can do about it?
Well, that's HDL is a component of the cholesterol, and that's usually treated by the cardiologist. But the most important number is really the LDL, and try to get it as low as possible. If you do have coronary disease, as Dr. Ghahramani mentioned, in patients who have coronary disease, we preferably like the number under 50, and some are suggesting that the number be under 35. So, and that's done with the aid of statins, other medications like Repatha if you can't use statins, and obviously diet and exercise are the initial steps in trying to bring it down.
Dr. Ghahramani, is there always the bad cholesterol that's the culprit of heart diseases, or sugar? And when is it necessary to take cholesterol drugs?
It could be either, or sometimes combination of one. The LDL, which is your bad cholesterol, is usually the cause of atherosclerosis or down the road coronary artery disease. Then we have HDL, which is your good cholesterol. So that ratio of your bad cholesterol and good cholesterol are important. And on top of that, having diabetes or elevated sugars is by itself an independent risk factor of developing coronary artery disease down the road. With regards to when it should be treated, there's no individual answer for that. It really is personalized care and the specific situation of that patient. And as I mentioned earlier, depends on the risk factors, past medical history, and so on and so forth. But the number that you, regardless of your risk, the number that you really need to start treating the bad cholesterol or LDL is when you're in the 160 to 190 range, that independent of your risk factors, you want to start those patients on cholesterol medications.
What for both of you, what is the current thinking behind calcium supplements or Boniva if one has a calcification in the arteries?
That's a good question, and I don't know the answer to. I don't know if Dr. Lamelas.
There's been some research on it, but we're not exactly sure if that really is a major component affecting calcification within the heart valves or the coronaries.
Okay. Dr. Lamelas, how do you treat a valve leading, what is it? How do you treat a valve leading due to a birth defect?
So the most common birth defect in a valve would be a patient that has a bicuspid valve. But bicuspid valves could be normally functioning valves. They occur in 1.5 to 2% of the population, and some will live an entire life without having any problems. But bicuspid valves have a higher predisposition for stenosis or calcification or a leak in the valve. And somebody that we all know had a bicuspid valve and had several surgeries was Arnold Schwarzenegger. He had actually a few different operations to address his bicuspid aortic valve. So you can see somebody who's a weightlifter, maybe on steroids, and everybody probably attributed to that. I mean, he was one person that had a bicuspid valve that developed to become narrowed and calcified, and he required surgery. So again, the answer to that question is the most common congenital defect. I wouldn't say it's not a defect, it's a genetic predisposition that patients have would be a bicuspid aortic valve.
Dr. Lamelas, stay there a minute. We have a, this came in. Can arterial bypass surgery be performed in a minimally invasive way?
Yeah, so coronary bypass surgery can be performed minimally invasive. I mean, and basically that's for the valves, it's done on the right side of the chest. For the coronaries, it's done on the left side of the chest through an incision underneath the breast on the left side. And the most commonly it would be performed to bypass the arteries on the left side. But, we have other hybrid techniques where if a patient has a blockage on the right side, that could be addressed with a stent, and then we could bypass the arteries on the left side.
Dr. Ghahramani, are there treatments or methods available to reduce calcifications in the arteries?
Yes. But I think the important thing is when someone has calcification or elevated calcium score, not to really focus on reducing the calcification, but focus on reducing the risk of a heart attack. And the way we do that, the best treatment for that is lowering the cholesterol through diet, exercise, and medications. And again, the most common medication being statins. But if someone cannot tolerate statin therapy, then we have other non-statin options nowadays, including a group of medications we call PCSK9 inhibitors, such as Repatha. So the answer is yes.
Dr. Lamelas, if I have just been diagnosed with a leaky valve and am asymptomatic, how long could I wait before surgical intervention is needed?
Well, that's actually a great question, and it depends on the degree of leakage of the valve. I mean, if you have a severe leak in the aortic valve, that needs to be addressed. If you have, even as I mentioned before, even if you don't have symptoms, the same goes with the mitral valve. We know today that if you have a severe leak in the mitral valve, and there's better than a 95% chance that valve could be repaired, the patient should have a valve repair, because their long-term survival will be equivalent to somebody who's never had heart disease moving forward. So if you have a leaking mitral valve and you're asymptomatic and you don't do anything about it, what's going to happen is you may progress to have multiple episodes of heart failure, and the 5-year mortality after you've had multiple episodes of heart failure is 50%. So half the patients will be dead in 5 years if they start developing symptoms of heart failure. So we tried to avoid that. And we know with the technology and the techniques we have today, this is a very curable pathology that'll allow patients to live for an extended period of time in a very comfortable fashion without symptoms. And again, the quality of life is extremely important. And and I've had many patients over the years that have told me, I'm just going to wait and watch this. And then 5-10 years, they come back and they're in a different position where we could still help them, but the long-term results are not the same. So I think if you have a problem that can be addressed, you need to reach out to your cardiologist or your primary care physician so they could direct you to the appropriate person.
Thank you, Doctor. Dr. Ghahramani, why the blood pressure tends to be higher when you wake up? What could be done about it?
So your blood pressure should be pretty much the same throughout the day, and at night it should go down, but your blood pressure should not be elevated when you wake up in the morning. So if you notice that your blood pressure is elevated, with the cutoff being more than 130, with the top number or 80, the bottom number, then you should probably speak to your cardiologist or primary care provider to make sure that you don't need blood pressure medications. So,
Dr. Lamelas?
No, I mean, I agree. I think that the target goal is 130/80, and usually the best way to do it is to take 3 blood pressure measurements and sitting down, and then you take an average of the 3, and also if you're under an emotional state or you finish exercising, I mean, your blood pressure is always going to be a little bit higher because that's a normal response by the body.
Dr. Ghahramani, this is for both of you. This just in, should patients on statins start using the APIB test in addition to or in lieu of the traditional cholesterol LDL, HDL test?
That's still an area of research, and it's a little controversial. If you go by the guidelines, recommended guidelines, still your traditional cholesterol panel, which includes the LDL, is what you should go by. There are other tests now that they look at the other particles that are part of your LDL, and they have found out that those, even if you have a normal LDL, one of those particles is high, it still puts you at a higher risk of having heart disease. But we don't use that routinely, and we still use just a traditional lipid profile.
Dr. Lamelas, what are good exercises to do after heart surgery to get back to normal?
Yeah, I think that the most important is walking. And I always suggest to my patients that they walk several times a day and stay active. I think the worst thing you could do after heart surgery is be a couch potato. I mean, you really have to get up and move, and that will assure the quickest recovery.
Is Plavix safer than aspirin after mitral replacement, Dr. Lamelas?
Well, most of the time we recommend 1 aspirin a day, and the other option occasionally what we'll do is we'll start patients on NOACs, which is the most common one that everybody sees on TV is Eliquis, and those are blood thinners. We may choose one versus the other, but long-term management is usually aspirin. Now, some patients, a very rare patient, may be allergic to aspirin, and we'll place them on Plavix, but one way or another need to be on some type of antiplatelet agent, meaning aspirin, Plavix, but most commonly aspirin long-term to avoid the leaflets of the valve clotting.
Is mitral valve replacement warranted over valve replacement?
Well, for the most part, we always try to repair the valve. And in some instances, like the most common one would be if somebody has rheumatic valve disease, where the valve is very calcified and sclerotic and narrow, and those patients will resort to replacing the valve. But for the most part, patients that have a degenerative process of the mitral valve, we try to repair it.
Dr. Ghahramani, can you discuss blood thinners versus Watchman versus ablation?
Ablation is a procedure, is catheter-based procedure for the most part, for treatment of various arrhythmias, the most common of which is atrial fibrillation. So ablation serves the purpose of putting you in normal rhythm. Now, people, as Dr. Lamelas mentioned earlier on, people who have atrial fibrillation, the biggest concern and the biggest comorbidity is the risk of stroke. And that's why we put those patients on blood thinners such as Eliquis or other NOACs. In patients who cannot tolerate blood thinners, let's say they have a high risk of bleeding, or they've had bleeding issues in the past, there's a relatively new procedure called the Watchman device, that they basically, there's an area of the top chamber of your heart that's more prone to blood clot formation. They basically go and close that area off with a device called Watchman device. So the Watchman is only indicated if you are not a candidate for blood thinner. And there's a surgical way of doing that. I'll let Dr. Lamelas discuss too, surgically actually closing that area of the heart.
Right. When a patient has an existing clot in the left atrial appendage, well, so the clots in patients that have atrial fibrillation, clots form most commonly in a little outpouching of the left atrium, which is one of the chambers of the heart. And if the patient has atrial fibrillation, one of the treatments, as Dr. Ghahramani mentioned, is a Watchman device, but there is a surgical approach as well, which is a clipping of the atrial appendage from the outside. And that's done through a small incision on the left side, where we access the atrial appendage and place a clip on the outside. So there's two approaches that are very effective in doing this. And the main takeaway point from this is that decreases the risk of developing a stroke by up to even 50% in someone who develops atrial fibrillation.
Dr. Ghahramani, this just came into us. How does AFib differ from PVC?
AFib is an arrhythmia that originates from the top chamber of your heart. PVCs is premature ventricular contractions that every now and then the bottom chamber of your heart, most commonly your left ventricle, just fires an extra beat. And commonly patients who have PVCs, their main complaint is, I feel my heart skipping a beat. That's the most common cause of it. PVCs are relatively usually benign, and they don't result in long-term damage to your heart. Exacerbated by anxiety, caffeine, stimulants, so on and so forth. But AFib is a totally different ballgame. That's an arrhythmia from the top chamber, and it increases your risk of having a stroke.
Dr. Lamelas, after a stent replacement, when can I stop taking my medication?
Well, if a stent is implanted in the coronaries, and that's done by an interventional cardiologist, it's not done by somebody like myself, but if a stent is implanted in the coronaries, the recommendations are to stay on definitely aspirin for life, and another antiplatelet being Plavix or Brilinta. Those are usually recommended for 3 to 6 months, but if you could tolerate it for longer, I think it would be advisable.
Okay. Dr. Ghahramani, are there any non-medication treatments for familial hypercholesterolemia?
Yeah, people with genetic hyperlipidemias, such as familial hyperlipidemias, tend to have really high cholesterol levels. So usually they end up needing medications. But as I always tell patients, not just with familial hyperlipidemia, but any sort of hyperlipidemia, diet and exercise are the best ways to reduce your risk of having a heart attack and lowering your cholesterol.
Dr. Lamelas, talk about diet. What's the best diet for heart disease?
Well, if the best diet is a plant-based diet, the problem with that is that in some patients it may be very difficult to adhere to, and there's a new diet that that we're hearing more and more in the literature is the flexitarian diet, where it's mainly plant-based with supplementing occasionally with either meat or poultry or fish. And those are usually the best. And by the way, a plant-based diet theoretically is not only good for the heart, but for the kidneys, for every organ in the body. So that's something to consider if you are at a high risk for coronary disease in specific.
Dr. Ghahramani, how important is it to track my LPA?
Going back to the question that was asked a few minutes ago, the traditional way of really assessing your risk, it's still the standard cholesterol panel, which includes your total cholesterol, HDL, LDL, and triglycerides. Those little particles are not part of the standard monitoring of your cholesterol and cardiac risk.
Doctor, is cardiomyopathy curable? Is it hereditary?
Is that for me or Dr. Lamelas?
Yeah. No, either one. You could start with it, and I'll finish it off with my opinion.
Yeah, cardiomyopathy, which means weakening of your heart muscles and weakening of the contraction of your heart. The most common cause, as I mentioned, is coronary artery disease or heart attacks. And there are familial cardiomyopathies. There's a genetic cause of that. And there are many, many, many other types of cardiomyopathy. Generally, treating the underlying cause is the main way of treating them. And then we have a variety of medications to treat patients with cardiomyopathy.
Yeah, the cardiomyopathy, I mean, obviously I deal with different types of cardiomyopathy, but one that is pretty prevalent and significant is what we call hypertrophic obstructive cardiomyopathy. And that's when not only the walls of the heart muscle enlarge, but the septum, which is the wall that divides the right side of the heart from the left side of the heart, becomes very thickened, and it obstructs the blood flow that leaves the heart. And we initially start the patients on several medications to decrease the pump function of the heart. But with time, when that progresses, as Dr. Ghahramani, there are some medications that are used. There's one that just came out, which is a myosin inhibitor that it works a third of the time. It doesn't work another third of the time, and another third of the patients, there's no benefit at all. But the most common treatment that we have today is called a septal myectomy, where that portion of the muscle is shaved off, and that improves the blood flow leaving the heart. And that's probably the most effective treatment we have for that hypertrophic obstructive cardiomyopathy.
Thank you, doctor. This just in, is feeling a flutter in your heart every once in a while indicative of a heart attack? Dr. Ghahramani and Dr. Lamelas, both of you.
The most common symptom of having a heart attack is chest pain. If you have fluttering in your heart or palpitations, it may be indicative of an arrhythmia or PVCs that you mentioned earlier. The best way of evaluating that, obviously you see your primary care doctor and cardiologist, is to put you on a heart monitor to really see why you're having those symptoms. We can correlate your symptoms with the EKG tracing to see where it's coming from.
Dr. Lamelas?
No, I agree. I mean, if you're having the fluttering, the best way is obviously to start with a simple EKG in the doctor's office, and if they are not able to pick it up, then a heart monitor, which could be for 1 or 2 weeks, and that would definitely be much more sensitive.
Interesting. What are some treatments for pericarditis?
Pericarditis.
Pericarditis, yes, that's it.
The most common treatment is an anti-inflammatory, which the one we have today is colchicine, and colchicine is used very commonly in patients who have gout. But what's interesting, a big topic in cardiology today is the inflammatory reaction that patients have in their coronaries. And we're seeing today that even a medication like colchicine, which was used to treat gout, can also be used to treat pericarditis. but also maybe an important therapy in coronary disease as well. And that's very early now in research, but there's a lot of research that needs to go into that. The second line therapy in somebody with pericarditis would be steroids. And then patients who have intractable pericarditis, they could be treated with another medication, which is an interleukin, which is a much stronger anti-inflammatory that's used. But that's usually a last resort in patients with pericarditis.
This is the last question. With regards to your research, what are the most critical problems that you're working to solve right now for both of you?
You want
to? There's obviously cardiology and cardiac surgery. There's a vast area of research, ongoing research, new technologies, new medications. And actually cardiology and cardiac surgery are the highest researched fields in medicine. I think that the biggest area of interest right now is ways of, and some of these have been asked throughout this Q&A, finding ways to identify risk of having a heart attack early through cost-efficient ways. And we have already mentioned some of them, but they haven't been mainstreamed yet, but we're getting there.
From a cardiac surgery standpoint, I think the ultimate goal would be to develop a valve, as we talked early on, that would last the patient a lifetime with the least number of blood thinners possible. And even in the field of coronary disease, we're also, investigating, as Dr. Ghahramani mentioned, not only ways of detecting heart disease early, but also in preventing the progression of coronary disease. And this is a constantly evolving field, and it changes on a daily basis and on a yearly basis. And even in my 33 years in cardiac surgery, I've seen a tremendous advancement in the field of cardiac surgery, and it's only going to get better, and we're going to save more and more patients' lives. And we see patients now older because of the fact that we have ways of treating some of these diseases that we didn't have many years ago.
Well, that's the last question. Dr. Lamelas, would you like to wrap up and give us your thoughts as we go into the final minutes here?
Yeah, no, thank you very much, Tony. I think this has been great. I want to thank all the viewers. I mean, I think the attendance and the questions were excellent. And I just want to emphasize that we are the busiest center in cardiology and cardiac surgery, not only in Dade and Broward County, but in the state of Florida, which many patients don't really realize that. And on top of that, I think it's also very important to focus on going to a physician that has experience and sees the pathology that they have on a frequent basis. I mean, there's no replacement for experience. And I think that's one of the big takeaway messages. And I think it's also important that that we are in a constant evolution of trying to develop new technologies and new procedures to advance the field of cardiac surgery. And the generosity that patients provide us ensures us to move forward with this mission. And we're determined to change the face of cardiology and cardiac surgery moving forward. And we appreciate venues like this because not only educates the patients, but it also keeps us in vigor to keep doing what we're doing on a daily basis.
Thank you, Dr. Lamelas. Thank you, Dr. Ghahramani. And thank you all for participating in tonight's In the Know Town Hall. Please remember that a full recording of this program will be emailed to you. Look for the link in coming days. I want to say something. Can you listen to these doctors? Can you think of any other reason why you would want to go anywhere else than the University of Miami? Think about it. In a moment, you will see a survey about tonight's town hall on your screen. Please take a minute to submit it. Your feedback will help us figure out what we can do next for our program. As always, we wish you and your family good health. And remember, it's all about the you. Thank you, everyone.